right, Sanjay Gandhi, ex-graduate from in MCH, postgraduate in MCH from Sanjay Gandhi Institute. And his special interest is that he started neuroendoscopy since the year 1999 and has used the neuroendoscope for various skull-based interventricular and spinal procedures. And if you can really be amazed, he has mastered the technique of neuroendoscopic disc surgery and has performed 1,800 such operations. I mean, that's a very awesome number. You have to really acknowledge that. And with very low complication and excellent results. He has designed a new innovative medical device, which is Endospine Plus, which is also called Satnam's device. And this is a very safe, economical, and simple. I bought one of that, and this technique has been published in Acta Neurosurgical in 2019. So you can see his feet, and he is recipient of Best Scientific Program Award, recipient of Distinguished Service Award, DMJ finalist in Healthcare Innovation, Time Health Awards. He has got membership of various important societies. Congress of Neurological Surgeons USA, Neurological Society of India, Neurotrauma Society of India, Stereotechnical Functional Society, and he has got also innumerable publications. I therefore have the pleasure to invite now Professor Satnam Chawda to start his deliberations. Dr. Chawda, please.
Thank you, Professor Pathak, for the nice, kind introduction. Thank you, Professor Sankla and Professor Pathak, for inviting me to give this talk on endoscopic versus microscopic discussion. Can I share my slides? Can you hear me?
Yes, sir. If you can come a little closer to the mic, it will be good, sir.
Graduate from in MCH.
Yeah.
Postgraduate in
Okay now?
Yeah, it is okay now. Yes, sir. Yes, sir. This is okay.
And his special interest is
I am going to speak on endoscopic lumbar dissection versus microscopic dissection
for various skull-based interventricular and spinal procedures.
Before I go to the main topic, I would like to briefly touch upon the history of
he has mastered the technique of neuroendoscopic disc surgery and has performed 1,800 such operations. I mean, that's a very awesome number. You have to really acknowledge that. And with very low complication and excellent results. He has designed.
technique, and he performed an extradural approach for that. And then in 1977, two stalwarts of neurosurgery, Professor Yazargir and Professor Kasper, both in the same year, 1977, independently reported their series of use of microscope in disc surgery. So microdiscectomy was born in 1977, and they reported in a same journal in the same year, same volume, you can see. And it was reported by them simultaneously but independently. Then Hijikita in 1975, he reported first percutaneous nucleotomy, but it was reported in a Japanese journal, so it was unnoticed in Western literature. And then it was Cambin in 1986 who reported his series of percutaneous discectomy and described what is known as Cambin's triangle through a posterolateral approach. Anthony Young in 2003, he applied transforaminal approach under continuous irrigation, what is known as arthroscopic approach. And then Rutan from Germany in 2009 reported used the same technique under irrigation through interlaminar approach. It was 1997 that Foley, Kevin, and Smith, they reported microendoscopic discectomy, and he designed a special trocar and endoscope through which the surgery was performed. It was marketed by Medtronics. And Professor Destendo in 1999, he reported his device where he made a conical tube with 3 channels in it and with 4 mm telescope. It was in 1999. Then Ortel, Professor Ortel, who is supposed to be here, probably he's coming. So he published his device in 2009, EasyGo first generation. In ACTA, it was published. I started endoscopic disc surgery and I learned it from Destendo in 2003 and started using his device. But then I realized certain limitations, so I modified this device after about 100 cases. In 2005, I modified it to a simpler device, which I'll tell you a little later. And this was published in 2019 in ACTA. I named it as Endospine Plus. Our Professor Mazhar Hussain has also published a device for endoscopic disc surgery in Journal of Neurosurgery in 2005. Now, so from history, you can see the lumbar disc surgery has evolved from laminectomy and discectomy to open interlaminar discectomy to microdiscectomy, which later became gold standard for this treatment, and then transforaminal endoscopic discectomy and microendoscopic discectomy. And you can see from this, in the whole evolution has been just the minimalization. We have not repaired the disc. We still remove the disc what we were doing 100 years ago. Only thing, minimalization has taken place. Can you hear me properly?
Yes, sir. Yes, sir.
Hello?
Yes, we can hear you, sir.
Right. So I am going to talk about microendoscopic discectomy. But before I go to my topic of microendoscopic discectomy, I will share with you a few interesting articles about microdiscectomy. Microdiscectomy, as we all know, is the gold standard. And I'll show you this Cochrane review of 2007 about surgical intervention for lumbar disc prolapse. And here the authors have concluded that microdiscectomy gives broadly comparable results to open discectomy. That means long-term results of open discectomy and microdiscectomy are same. There is another comparative study, prospective randomized study to compare macrodiscectomy and microdiscectomy. And here also, it was published in 2006, not very old. And they also concluded that there was no significant difference between two surgical procedures in frequency of use of analgesics or post-operative VAS score for sciatica. So they concluded that for lumbar disc herniation, both macrodiscectomy and microdiscectomy are prospective randomized study to compare macrodiscectomy and microdiscectomy of the patient. And here also, there is another paper published in British Journal of Neurosurgery in 1996. And they also concluded that there was no significant difference between two surgical procedures in frequency of use of analgesics. And here also they have come to the conclusion that use of analgesic medicine and the presence of pain in back that for lumbar disc herniation, post-operative macrodiscectomy and microdiscectomy prospective randomized study to compare macrodiscectomy and microdiscectomy. Long-term outcome of another paper published in British Journal of Neurosurgery in 1990, and they also concluded that there was no significant difference between two surgical procedures in frequency of use of analgesics. Now coming on to also they have come endoscope versus analgesic, as we all know, and they concluded that lumbar disc herniation, post-operative small incision microdiscectomy you can prospective randomized study to compare the scope gives a general angle of view. Then long-term outcome of another paper published in against the part better medication, and they also concluded that there was no significant difference like a microscope in the operating field frequency of use of analgesics. Now coming on to also they have come endoscope versus analgesic, as we all know, and they concluded that lumbar disc herniation post-operative small incision microdiscectomy you can prospective randomized study to telescope gives you a wide angle of view. Then on the outcome of another paper of 2010 and far better magazine. And they also like it that the perfect telescope works like a microscope in the operating field. Frequency of use of energy. Now coming on here also they like endoscope also. And as we all know, and they concluded that lumbar disc is most of both the small and this study indication is not as long as the telescope gives you a wide angle of view. Then on the outcome of another paper of 2010 and far better magazine. And they also like it that the perfect telescope works like a microscope in the operating field. Frequency of use of energy. Now coming on here also they like endoscope also. As we all know, and they concluded that lumbar disc is most of both the small and this study indication is not as long as the pictorial is not on the outcome of another paper of 2010 and far better magazine. And they also like it that the perfect telescope works like a microscope in the operating field. Frequency of use of energy. Now coming on here also they like endoscope and as we all know, and they concluded that lumbar disc is most of both the small and this study indication is not as long as the pictorial is not on the outcome of another paper of 2010 and far better magazine. And they also like it that the perfect telescope works like a microscope in the operating field or microscope. Now coming on here also they like endoscope and as we all know, and they concluded that study indication is used in 1997 by Kevin Foley, and this is basically hollow cylindrical tube which comes in 2 diameters and 2 lengths, and it accommodates 3 millimeter angle telescope. It needs a fixation device, and then you perform the surgery. So it came with a big bang then, but then people were not very comfortable because of the probably due to 3 millimeter telescope, the video quality was not very good. So people were not very comfortable. So they started using, even Kevin Foley started using trocar and then a microscope. So they called it tubular microdiscectomy. So, and then this descendo tube, I started using this tube. This is a conical tube with elliptical shape in transverse section. The advantage of elliptical shape is it docks direct put on the lamina, even if there is a facet hypertrophy. So docking is much better. And it uses a 4 millimeter telescope. This is the channel for the telescope. So video quality is very good. You don't need to fix it. You can move it up and down as with your movement of hand and instrument. So it's relatively easy to use. I performed first and 100 surgery with this. But then I found certain limitations in learning. Number one was that these channels, this channel is for the suction, this is for the working instruments. And the problem is they move in a fixed direction because these channels are very small and then instruments move in a fixed direction. You can't change the angulation between them. And at some point, they will collide with each other. So like if you want to use suction and Carrison punch, so maybe you'll have to withdraw your suction a little bit and then you can't use it simultaneously. You can't cross it. So that was limiting the learning part. Maybe after practice, you can, or with practice, I could also learn that, but that was a bit of a learning problem. And you can't cross your instruments like you do under microscopic vision, that you can't do it under this. So I thought, why should we have this solid component? Why not make it hollow, like Medtronic tube, and it will be easier, you can cross. And the second point is that this diameter is quite big. So incision would become about 2.5 centimeters. So even microscopic surgeon can do it under 2.53 centimeter incision. So again, the advantage of incision is so this, but this is very economical system. And then you need a special bipolar forceps and all for this. So this is what I modified. I made it smaller in diameter. It is about 2/3 of its maximum diameter. And it is hollow from inside. It has got 4 components: outer tube and an obturator, inner tube, which accommodates a telescope of 4 millimeter, and a self-retaining retractor. This is how after it is assembled into. So you can use your instruments freely, you can cross your instruments, change the angulation. So surgery becomes more like microscopic or transnasal surgery, and you can do. And it moves freely, doesn't require any fixation. It uses 4 millimeter telescope. You can use your normal bipolar, normal knife, So you don't need any special instruments, just this device and telescope and camera system, and it is very economical. So I found it very useful for last almost 15 years or more than 15 years now. I've been using this. More than 1800 cases I've operated with this without any problem. This is what I showed my publication in 2019. EasyGo system is EasyGo 2 hotel modified it further in early 2014, and this is cylindrical and it accommodates 4 mm telescope, which was a limitation with Medtronic system. They were using 3 mm, so here video quality has improved. I believe this is a good system, but I've never used it. Maybe when Hotel joins, he will explain it a little more. Now coming on to the indication of microendoscopic discectomy. Microendoscopic discectomy indications are same as that of for microdiscectomy. All type of lumbar disc diseases can be operated, like sequestrated disc, contained disc, migrated disc, central, lateral, far lateral disc, canal stenosis, single or multiple level. So you can operate anything with this technique. Now coming on to the positioning the patient. Earlier I used to position my patient on a Wilson's frame and make the back little convex. But then I realized that probably this position is better with a natural lie of the natural concavity of the back and two bolsters, one under the chest, another one under the pelvis. And this reduces the extradural bleeding, chances of dural tear. And this is the position where you can achieve the best decompression for canal stenosis, because canal stenosis is maximum in extension posture. So this is the best you can achieve in canal stenosis. So I like this position. So nowadays I use this position. I used a Destendo localizer device to follow mark the level of disc. And then a small incision is marked about 10 to 15 millimeters from the midline on the side where you want to go. And you make a cut in the skin fascia and then put your scissors through the muscles close to the spinous process, touch the spinous, touch the lamina. And there you use a oxytocin to strip the muscle from the lamina and then introduce this tube. And this is how the tube is used. Freehand, doesn't need any fixation. Tube is, since the endoscope is fixed with the tube, so it always follows the tube. And so tip of your instruments are always under vision, never a blind area. And you can use a drill, Carrison punch, pituitary, knife, bipolar, everything through this tube. You can see this is quite easy to use and quite stable. No problem. This is just an external and so just a small incision. And this is the endoscopic view of L5S1 discectomy on the left side. And you can see this is the medial, this is the lateral, this is the cranial and caudal. This is the lamina, lower edge. You perform the fenestration. This is the ligamentum flava. You go up to the attachment of upper limit of ligamentum flava, free the ligamentum flava, then gradually remove it. And this is the exposed dura and the nerve root going down, traversing nerve root here. The nerve root is being retracted, and this is the bulging disc under the nerve root. You can see this is the bulging disc. So an annulotomy is done with a normal knife, 15 number blade, and then with a normal pituitary ronger, you remove the disc, like it is done under microdiscectomy. So basically, the procedure is same. You can remove the disc as per your philosophy. You can remove just the free fragment or go into the space to remove the disc as much as you like. So there is no limitation. So now the nerve root is free. And this is to show how a drill is used in this device. And you can notice that I'm just holding freehand the device and how stable it is. The drill is being used, suction is being used, and tube is hardly any movement. Tube is quite stable. You can just move as if you want to see medially, you moves also. So you don't have to really release the fixation and waste time there, up and down, medially, laterally. Really, you can move the tube and use a drill for fenestration. This is contralateral decompression and all that. Everything can be done. So this is a video of par lateral disc. L4, 5, you can see this is a par lateral disc here, extraforaminal. And so instead of interlaminar approach, this is the lamina on the right side, L4, 5. And this is the lateral edge of the pars. Normally we go intralaminar here. Here we go transverse approach. This approach is known as intertransverse approach for par lateral disc. And you perform a small fenestration here on the lateral edge of the pars interauricularis. And then you expose the exiting nerve root, because par lateral disc, it moves up and presses the exiting nerve root, the ganglion on the exiting nerve root, and it is a very painful condition. So after fenestration, you expose the lateral edge of the ligamentum flavum, remove that, and then you expose the exiting nerve root. This is the exiting nerve root. And these par lateral discs are generally free fragments in the axilla of the nerve root. You can see this is the nerve root, and this is the axilla. You can see there is a free fragment there. So very minimally invasive. Stability is maintained. Now the nerve root is free, exiting nerve root. Okay. So in last, since 2003, I've operated more than 90, nearly 2000 cases, more than 1900 cases, out of which endoscopic discectomy in nearly 1500 and 438 canal stenosis. Endoscopic discectomy age ranged from 14, youngest patient was 14-year-old, eldest was 82. 2 levels I've operated in one patient in 102 cases. And this is the distribution of endoscopic discectomy. L4, 5 and L5 S1, they were the maximum cases. About the complications in my series, there has been no major complication, no nerve root injury in this series. Minor dural tears in 35 patients. Fortunately, I never had to open up the incision to repair dura. There were minor tears which could be repaired endoscopically. So never had to open and repair and everything under microscope. Discitis in 1 cases. 13 recurrences I've operated. So recurrences have been low. Some of them might have gone elsewhere, but 13 I've operated out of 1500 cases. So outcome was good to excellent 93% of patients, fair in 6 and poor in 1 patient. This just to show you example. This is a L5S1 on the left side, sequestrated fragment there, and this is the post-operative picture of the same patient. This is another big fragment centrally protruding. This is an inferiorly migrated disc which could be removed easily, not a problem. This is central disc L3-4 level. So you can operate everything. So advantages of endoscopic discectomy are it is minimally invasive, lesser iatrogenic trauma, smaller incision, less painful, early discharge from the hospital, and quick return to the work. This is an actual patient, my operated patient. You can see the size of the incision, which is so small that it could be covered with a bandage. So this is the actual incision. And this is just to show you how the patient, just before the entering the for surgery, how he was walking. See your sciatica. And this is same evening he is walking comfortably, straight. So patients are mobilized within hours and sent back in 12 hours. So now coming on to the comparison with the routine microdiscectomy, Clark and Foley, they performed a meta-analysis and of difference between tubular microdiscectomy, which included both microendoscopic and microscopic tubular discectomy and routine microdiscectomies. And in 2017, it was published in Journal of Neurosurgery, and they found 10 manuscripts where this analysis difference was analyzed. And 6 of them were randomized controlled trial where they had divided cases into MED and microdiscectomy, and 4 retrospective comparative studies. And this is the number of cases. One thing important to note is that most of these studies are quite small, 50 or less than 50 cases. So really, I feel even 50 is just a learning curve status. Maybe after 50, 100 only you get enough experience that you can master the technique. But so in this comparison, what they have analyzed, the complications, you can see most of the studies, but they were the same. CSF leak, again, same. Reoperation rate, same. And they are randomized controlled trials. Recurrent disc herniation, in one study there is slight increase, otherwise most of the studies same. Infection decreased in some studies and some studies just the same. And estimated operation time is almost same. In one two study it is increased. In some studies, yes, it is increased. Estimated blood loss again reduced in time to mobilization again same. Analgesic use it is decreased. Length of hospital stay same or decreased. Short-term outcome it is same in both endoscopic and microscopic, and long-term outcome again it is same. So the result from their meta-analysis is that similar clinical outcome can be expected from both endoscopic and standard microdiscectomy. Overall rates of complications were no different in MED and standard discectomy like dural tear and recurrences. Equivalent operating time for both the procedure. Lower blood loss and shorter hospital stay was associated with MED. Post-operative analgesic use has been shown to significantly lower after MED, and infection rate is lower after MED. They say infection rate is quite low with MED, probably due to a smaller incision and less dead space. So infection rate is quite low in comparison with the open discectomy. This is the Cochrane review published in 2014, where they have compared minimally invasive discectomy versus microdiscectomy. In minimally invasive discectomy, they have included both tubular and percutaneous transforaminal discectomy, and really they found no significant difference between minimally invasive and microdiscectomies, and almost same outcome they have reported. Little advantage here and there, but no clinically significant advantage. This another paper published from India where they have compared MED with microlumbar discectomy, and they have also found no difference between the two techniques in the outcome. This is another paper published on China, and they found a good outcome with MED. This is from Mumbai, microendoscopic lumbar discectomy. They also reported a good outcome as with microdiscectomy. This is another meta-analysis published 2019 in Journal of Neurosurgery, where they compared endoscopic discectomy with microdiscectomy and tubular microdiscectomy. And outcome of tubular microdiscectomy and open microdiscectomy for lumbar disc herniation are largely equivalent. This is what they concluded. So here is one paper. They have studied various inflammatory markers with MED and non-MED, and here they found some lower level of inflammatory response and reduced invasiveness in MED cases. So where endoscopic surgery clearly scores over microsurgery, in my opinion, here you have a definite smaller incision. It is very important, especially it is more important in younger patient in our country, where marriageable age, we have a system of arranged marriages. People are very concerned about cosmetics and they don't like any bigger incision. It is certainly less traumatic. It is very good in obese patients, because in obese patients, if you want to do microdiscectomy, you really have to make a big cut to go to the depth. So here the incision size remains the same. You operate however it is still the same. Contralateral decompression, you can do far better with the endoscope than microscope. Then why is MED lagging over microscopic? The problem is steep learning curve and lack of training because it is not easy to learn it. That is probably I feel that is where it is lagging. So to conclude, for lumbar discectomy, level 1 evidence supports equivalently good outcome for both tubular microendoscopic discectomy compared with the standard microdiscectomy. And level 1 data indicates similar safety profile and may indicate lower blood loss for tubular microendoscopic discectomy. However, further studies should be conducted for the comparative value of these two procedures. And before I end, I'll quote a statement from Clark and Kevin Foley's article. They have very nicely written that novel techniques have become the gold standard in the face of level 1 evidence, demonstrating equivalence to the prior widely accepted technique. That means, like most notable is standard microdiscectomy itself. The Cochrane review has demonstrated clinical equivalence of microdiscectomy to open discectomy. Prospective randomized controlled prospective randomized studies have also demonstrated similar clinical outcome, pain medication use, complication, and hospital stay. Still, microdiscectomy has become a gold standard, while the outcome with the previous techniques were still the same. Likewise, level 1 evidence demonstrates equivalence between instrumented and non-instrumented lumbar fusion with respect to clinical out improvement, complications, hospital metrics, and fusion rate. And still, the instrumented one has become a gold standard these days. So these data highlight how in the setting of equivalent outcomes, technological advances and shifting patients' preference can guide changes in the treatment in modalities. That is to show that microendoscopic discectomy is showing equivalent to the, as per present scientific data, it is showing equivalent result to the microdiscectomy. So maybe in future, because of better acceptance and widely availability, it can become a gold standard, maybe better training. So if we push for it, maybe in future it can become a gold standard. Thank you very much. Thanks for the patience. Thank you so much.
Professor Chavda, that was a very comprehensive sort of elaboration of all the great work that you have done, and of course, very extensive discussion on the literature as well. I would now invite the panelists to sort of take up the discussion further. Can we request Dr. Rohidas to give his comments, please?
Hi, Satnam.
Hi.
Why do you feel that you want to change it?
Change it means what?
You
changed microdiscectomy.
It is a modification of EasyGo and distend.
In comparison to?
It is a modification of distend to EasyGo. You have created a more space inside the inner tube, just like a EasyGo.
Yeah.
Instead of angle scope, you are using a zero degree.
So I am happy with my system. I am very happy. I am using
that. The youngsters would like to know why you want to change it. Why you thought of changing it?
Changing my scope. But you don't like this thing, or with Distendo, or with the EasyGo?
You have modified the Distendo thing. It is a combination of a EasyGo and Distendo. Correct?
Yeah.
The youngster would like to know why you thought of modifying it.
Yeah, I explained it this thing because now my tube is smaller in diameter, so incision becomes further small, and it is easy to manipulate the instruments in that tube because it's an open tube, no fixed channels. So you can change, like in the normal microsurgery, you move your hands like this, change the angulation, you cross the instrument. Sometimes you use suction as retractor. You are sucking still with the same suction, you are retracting the nerve root little bit and doing the surgery. So it's like microneurosurgery. But while it is not possible with that system, I felt so. So this is what I'm showing you, my experience. I think you might be having different experience, but that's my experience.
No, the youngster should learn. the basic philosophy behind it.
Yeah, I told you
No,
that because like you can change the angulation, you can cross the instruments, you can use normal bipolar, all those things are there.
After doing 2000 cases, do you think the size of the incision in millimeters matters, or what you do at the site of the pathology matters?
That is a question what microdiscectomy people asked us.
No, it's not about the endoscopic thing, anything.
Anything. That is the whole topic was that okay comparison between microdiscectomy and this. So even if we really reduce incision by 2 millimeters, if I can do something with 5 millimeter, now Dr. Sukumar will talk. He will give a 5 millimeter incision, and then he would say that is better.
So that is what
every millimeter counts. Every millimeter counts.
No, that is what the youngsters should know.
Yeah.
They compare
now next talk will be Dr. Sukumar. He will say 5 millimeter
what happens at the site of the pathology during surgery, which is important.
It's true. We have to achieve that goal. That goal, ultimate goal, is the most
important thing, not the incision in millimeters.
Is Dr. Sumit Sinha there? Is Dr. Sumit there? Sumit Sinha?
Yes, sir. Yeah, a very important discussion actually regarding this size of the incision. So, very rightly said. I mean, the size of the incision does not really matter actually. What matters is that your patient should benefit from the type of the surgery and the kind of the surgery that you are going to do on your patient. And so that you do not have to see the sad face of a patient in your clinic in the follow-up. So that is the most important thing that a young delegate, young practitioner has to understand. Now coming to the modification, the question which Dr. Rohidas was asking repeatedly from Dr. Satnam, I mean, as to what was the need for modifying this instrument. So if you ask me as a newcomer about some maybe 8 or 10 years back, when I started using this Destendu system, when I first saw this Destendu system, I was quite intrigued with the system and sort of, not very comfortable using this system in the first instance. Why so? The reason was that the reason was given by Dr. Satnam only, who I also felt that we as neurosurgeons working under microscope have grown up using the instruments in a parallel fashion like this, off and on and on, like this, not like this actually, which happens quite frequently in the Destendu system. So this is a quite of difficulty in accepting that system. I'm talking about the Destendu system. So probably that was the reason that people switched over to EasyGo, those who do an EasyGo system or those who use the tubular retractor type systems. So this was one particular difficulty which I, as a newcomer in the spinal endoscopy, found in the Destendu systems or similar type of systems, which might have prompted Dr. Satnam to modify this Destendu into a more EasyGo-like looking system, maybe. And this was true in my case also, and maybe in other young practitioners who start using this conical type of system. What matters to me the most is whatever type of surgery you do, whatever endoscopy or open, it is the result or the surgical outcome that your patient should not come to the OPD clinic with recurrent or non-responsiveness of pain.
Dr. Rashim, please.
Yes, sir. So the only thing I find interesting is by changing the instrument from a circular to elliptical, it addresses the facet hypertrophy problem which might be there when the facets are hypertrophied. The circular tube, it certainly poses some problem when the facets are hypertrophied. The elliptical tube rests nicely on the lamina. So this is all, I feel so.
Thank you very much. I think we have to honor the time and give time to the other speakers. So with the
Professor Ashish, Professor Ortel is already there.
Right.
I don't know whether he...
If he wants to start his talk, you can introduce him and go ahead.
Yeah, sure. So is he around? Joachim, are you connected or you're not connected?
No, I'm connected. I don't know.
Are you ready for your talk or shall we?
Oh yeah, we can do it. Whatever you want.
Okay, fine. So let us do it then.
Okay.
All
All right, friends. All right, friend. It is my privilege to introduce Joachim Ortel. He is well known to all of us, and he is well known to our Indian neurosurgical societies and endoscopic societies in particular. He is presently chairman at neurosurgery department at the University of Saarland, which is Hamburg in Germany. Joachim has been very active in development of the neuroendoscopy right from its beginning, and he's very actively participated in all activities organized by the IFNE. He had a particular interest in educating and training the endoscopic neurosurgeons, and you will find him in all the hands-on workshops and seminars and neuroendoscopic workshop and conferences all over the world most of the time. He has a special interest in India over the years. He has visited India so many times and helped us developing neuroendoscopy in India as well. He has been an orator in our conference 2 years back of the Neuroendoscopic Society of India. Large number of publications and credits and book chapters and everything on his name. I wouldn't have time to enumerate all of them, but he is well known to all of us, and he is an asset to the world neuroendoscopy, and it is really my privilege to introduce him today. Welcome, Joachim, and please unmute yourself and share your screen with us. He's going to talk about the lumbar canal stenosis endoscopic treatment. All
Thank
yours.
you so much. Let me see that this works. So you see my slides?
Yes,
Yeah.
we can.
And you can hear my audio?
Yeah.
Yes. Can you come a little closer to the speaker so that we can hear
like
you better?
this?
That's much better. Please go ahead.
Okay.
Yeah.
Yeah. Unfortunately, we have a lot of snow here, and somehow I have a bad Wi-Fi over the last weekend. So we will try to make it as good as possible. Well, thank you for the nice introduction. It's a real pleasure to be back in India, although it's just a virtual webinar series. It's not a physical meeting. And it's a particular pleasure to be part of this webinar series because I think the Neuroendoscopic Society of India is one of the very few who really tries to incorporate the spine endoscopy in the Neuroendoscopic Society. So I think this is of a very particular, and I think I congratulate you on this effort a lot. So my presentation today is is a lumbar canal stenosis and endoscopy. I have some disclosures which are unrelated, I think, to the presentation today. And this is where I'm from. Many of you have been visiting us already, but this is now, I used to work in Hanover, then later in Mainz, in the beginning actually in Greifswald. And now I'm here at the southwest border of Germany. Homburg, it's an O, not an A. So Homburg, very small city, just 10 kilometers from the French border. You see here, this is Strasbourg, is here, Frankfurt, Luxembourg, so in the southwest Germany. This is the department. It's this is the university campus. So here is the ENT building, the main entrance, and you see here, this is the so-called Nervenberg. So all the neuro subjects, all the neuro fields are here in this area. And this is the OR of the neurosurgery department. It's spine and surgery is a very traditional field for the neurosurgery department because when you remember that maybe Kasper competed with Yashagil about the first microdiscectomy, which was done in this here at this university campus, and the development of all these Kasper systems and everything was done here in this department. So we do about 300 to 400 endoscopic procedures, 300 to 400 MIS spine fusions in this department. Well, this is what I meant. It's a particular pleasure to present this in the Neuroendoscopic Society, because actually spine endoscopy more and more goes into spine surgery societies, and it's not covered by neuroendoscopy that frequently anymore. And I think this is a real pity, because it's a wonderful field for application, and a lot of cases we miss if we don't continue with our research and effort to bring endoscopy of the spine in our neuroendoscopic society. So the theoretical advantages is a very high magnification. You can look around the corner, which I think is not that important in most of the spine applications. In most of the spine applications, we don't use angulated optics. We use straight optics or 25 degrees optics. But when we think about brain endoscopy, the look around the corner is very important. We try to reduce collateral damage, and I think this is the main advantage of using the endoscope in spine. And ideally, we have a new surgical technique like ETV in neurosurgery or transfemoral and spine endoscopy in selected cases. Well, in contrast to other endoscopic indications, we have no preformed cavity. So we have to create our space to maneuver the instruments to bring in the endoscope. And in contrast to many other endoscopic indications, we have already very good results with microsurgery. So we need also decompression of neurostructures, sufficient decompression. So we have a little bit of a dilemma. We have already very good results with microsurgery. We have to create a space to bring in the endoscope at all. And then we need sufficient decompression of neurostructures. But I hope at the end of my presentation, I will try to convince at least part of you that the endoscope will play a significant role in spine surgery in the future. What about treatment of deformity and instability? It's difficult. And well, we can do MIS decompression, but most of the instabilities we actually do open with a microsurgical decompression and then fusion. So what are the advantages we use when we think about the endoscope in spine surgery? Well, we have minimal muscular trauma, and I think this is particularly probably the most significant advantage, to reduce the trauma of the approach. Then, because of the high magnification, you have a mini opening of the dura end of the spinal canal. This is not that important for spinal canal stenosis, and this is my topic today, but particularly if you have a sequestered disc prolapse, you just have sometimes a mini opening of 4 by 4 millimeters in diameter, and then you can just take out a significant big sequestered disc prolapse. There's a significant patient demand, and almost all spine cases I see in my outpatient clinic, they ask about minimally invasive procedures. It might be nonsense or not, but this is a significant patient demand we have to cover. Superior aesthetic results, less post-op pain, and faster recovery are the theoretical advantages. When we think about spine endoscopy, we have a very vivid, controversial discussion. One is against microscope versus endoscope. One is tube-based versus full endoscopic. One is transfemoral versus interlaminar. I think when we look at this for the lumbar canal stenosis, actually, it's quite an easy discussion, because we need sufficient decompression of the spinal canal. When we look at the status of evidence, microscopic versus endoscopics, there's so many data out there now. Well, most studies show that the recurrence rate and the complication rate is no longer higher than with microsurgery. We have some advantages, so less post-op pain, faster recovery, less muscular damage, less superior cosmetic results, but in the long term, we don't have superior results. Well, this is, from my perspective, not a problem. It's actually good that we have no longer higher recurrence rates and higher complication rates with the endoscope. So I don't have a problem if I don't have evidence that microscope versus endoscope, one is better than the other in the long term. Well, now I want to show you the technique we use for the lumbar canal stenosis. There are so many various ideas and approaches for the endoscopic approach of the spinal canal in lumbar, and I focus only on lumbar today. You see tube-based endoscopic assisted, percutaneous shear, full endoscopic. All these different approaches are available. There are two main principles. One is the interlaminar and one is the transforaminal. Since the lumbar canal stenosis, if it's severe central stenosis, is usually a little bit above the disc level, I think the lumbar canal stenosis is best treated with an interlaminar approach. It's not a good case for it in a transforaminal approach. So these are the various advantages, various indications we can discuss, but this is what we want to talk about today, a central canal stenosis with significant narrowing of the spinal canal. What is the status of evidence with visualization? We have now all HD cameras. We need a rigid rod lens scope. And these suitable techniques, particularly with the tube system, regardless whether it's a Descendant system, is a metric system, or it's an EasyGo system, gives us the right armamentarium for treatment of lumbar canal stenosis. So with these systems, no tight selection of candidates is anymore required. Just an example here. This is standard definition to the right, HD definition to the left. So if you don't have HD, if you don't have a diamond burst, probably it's not good to start the endoscopic technique for lumbar canal. We need some equipment to achieve superior results. So this is I just collected the data for a 2-year follow-up. This is our endoscopic spinal canal stenosis cases. We have done all these with the generation. I don't think it really matters for the results what kind of tube system you use. Even if you have a endoscopic system, you can achieve the same results, but the more workspace you have inside the tube, the better, and I think the easier it is to apply the technique. Surgical technique is absolutely identical with positioning, skin incision, and dilation of muscles to the disc, endoscopic disc surgery. The only difference is when you think about lumbar canal stenosis that we try to address the attachment of the ligament and the cranial part. So we do remove the lower part of the lamina, and then we detach the disc, the ligament from cranial to caudal. This is an example here. You see this is a typical canal stenosis, and this is a surgical example. We use a unilateral approach, 2 centimeter skin incision like this, and we insert the tube system, and then you address here the ipsilateral lateral recess compression and decompresses, and then you tilt the tube a little bit and decompress the contralateral side. In the beginning, usually we start with the decompression in the midline. Why in the midline? Because in the midline, as you see nicely here, usually there's a lot of space left. Even if a very narrow central canal stenosis, you have in the midline some epidural fat tissue, some remnant epidural fat tissue, so you can expose the dura and then come from medial to lateral. Why from medial to lateral? Because of the surface of the dura. It's the safest way to avoid CSF fistula. Why from cranial to caudal? This is from cranial to caudal. Why from cranial to caudal? Because the direction of the nerve root goes from cranial to caudal, from cranial medial to caudal lateral. So if you go in the same direction from cranial to caudal, the likelihood of injury to the nerve root is less. So cranial to caudal, medial to lateral. The last step, after we have decompressed here the ipsilateral side. This is lateral, this is midline, medial. So after that we have decompressed the ipsilateral side, we tilt the endoscope. I will forward it a little bit. We tilt the endoscope, and then with a 25-degree scope, we can decompress the contralateral side. That we can really do 360 degrees or at least 180 degrees decompression of the posterior neurostructures. So this is the contralateral side now. It's actually a little bit easier to decompress the contralateral side. The only thing you need, definitely, for the lumbar canal stenosis, different from the disc prolapse, you need a diamond burr. If you don't have a diamond burr, you will not be able to achieve a significant decompression of the contralateral side without the diamond burr. So the technique is like this. Here you can use a kerosene punch as usual, but when you go to the contralateral side, you drill a little rim in here, and then remove the remnant of the ligament with a kerosene punch. And this is an example here of a post-op CAT scan, just to show you the technique that you tilt the end of the tube a little bit and get the ipsilateral and contralateral decompression. All this is done with a 12-millimeter skin incision with this technique. We have a long follow-up now, 2 years follow-up with the EasyGo second generation on 30 patients with a lumbar canal stenosis. It's actually not the most frequent indication for us, the lumbar canal stenosis. We do the endoscopic application much more frequent in lumbar disc prolapse and in cervical applications. So the lumbar canal stenosis is the third most frequent indication in our hands. And one problem is that many of these patients had earlier surgery, and I will get back to this later in my final slide, or the almost last slide. And another thing is that frequently we have a significant facet joint pain with this. So when we have a significant facet joint pain, then actually we go for fusion. So about 1/3 of the patients we present with spinal lumbar canal stenosis, we fuse, and this is quite a significant number. So a total of 30 patients, we have a follow-up. You see, all operations were made unilateral, so only one was done bilateral. Actually, this one had several segments. So usually it's a unilateral approach. Then ipsilateral monosegmental and 4 ipsilateral contralateral monosegmental, so bilateral monosegmental in 13, bisegmental ipsilateral in 11, ipsilateral contralateral, so bilateral bisegmental in with 2 skin incisions in 1, and bilateral contralateral bisegmental in 1. You see here, this is a distribution of levels. So the most frequent level is L4-5, then L3-4, and L5 as well. So pretty much the same as in any other study. Operating time. Well, operating time depends on the number of levels significantly. So the median operating time for one level is 55 minutes. I think it's a little bit longer than we would use a microsurgical technique. So maybe it's an additional 15 minutes, I would guess, per level if you use an endoscope. All these procedures were done with the EasyGo set, as I said, and there was 24 of the 30 used the green trocar, and 5 the orange. So the green is the medium size, 80 millimeter, the orange is 50 millimeter, and in one case, we switched from the orange to the green. This was a patient with a very obese patient, and it was just not possible because of the depth of the surgical field with a small trocar to angle the instrument sufficiently. So there was not a sufficient decompression possible with a small trocar. There was no emergency stopping, no switch to microsurgery. and 50% of the patients left the hospital within 4 days. So this is always a difficult evaluation, since in Germany we have all these patients were treated as in-hospital patients, so there's no outpatient lumbar canal stenosis surgery. So all these patients stay usually at minimum 2 or 3 days after the procedure. 60% were mobile at the day of surgery. 97 were mobile at the first post-op day. So most of them were early discharged. With regard to paresis, pain, and sensory deficits, so in this group, 18, so 2/3 had a preoperative paresis. Of these 2/3, 89% improved at the 2-year follow-up. So it's a long follow-up, and almost 90% improved or had no paresis at the last follow-up. What about preoperative pain? Well, 100% had back pain, 90% had radiating leg pain. 2/3 had immediate pain relief, so they don't need any further pain medication, even in the long-term follow-up. 1/3 had declining preoperative pain, but they have some remnant symptoms, mainly back pain, like facet joint pain. So, but overall, they are very satisfied. Preoperative sensitive, let me go back. There was one patient who actually fused subsequently. It's not on this list. One patient, because of the persisting postoperative pain, we fused with a percutaneous instrumentation. Preoperative sensory deficit, 50% had a sensory deficit, permanent sensory deficit. And of these 50%, about 50% had a declining deficit, 50% had no deficit on the last follow-up. So when we summarize our own data, there's immediate pain relief in or decline of postoperative pain in 67% and respectively 100% in the last follow-up. There's no improved paresis in the long-term follow-up in almost 90%. We had 3 CSF leak cases, all were closed endoscopically, and I will get back to this in the next slide. There was no root injury, no new paresis, no postoperative wound infection, no switch to microsurgery, and in one case we had to switch from orange to green. And this is our technique for the CSF fistula closure. You see here, this is a CSF fistula. You see that the arachnoid membrane is still intact. There's a little bit CSF flow, but not too much. I will forward a little bit. Now we harvest some muscle tissue inside the tube. We put this muscle tissue, which should be exactly at the same size as the CSF fistula, as the CSF, as the dura leak. This muscle tissue or fat tissue is then brought into the dural leak, pushed a little bit inside, just that it stays there. And then we apply a taco seal, so it's a thrombin coated gel foam, and it glues this muscle tissue on the dura. With this technique, we have measured our time for endoscopic dural fistula closure. It's 2 minutes 40 seconds average. And so far, when we applied this, we haven't had any problem with a CSF fistula later on. And this is what it looks like. Even in such a case where you had the CSF fistula, you can really close the CSF fistula immediately intraoperatively, and it takes only 2 minutes 40 seconds. So why and when an endoscopic approach to lumbar canal stenosis? And this is the difficult topic we want to address now. And I will just give you some of my thoughts about this. Well, First, the area of dural exposure and dural decompression is almost identical with the microsurgical decompression. Yeah, it's right and not right. There is a significant muscular trauma if you do 2 or 3 levels despite the application of a tube system. Yes and no. The only advantage is a smaller skin incision and smaller visible scar. I don't think that all this is right. It's not wrong, but it's also not right. I will try to give my idea about this. The area of dural exposure and dural decompression is almost identical with microsurgical decompression. Yes and no. The area of decompression can be identical. It can be identical if you really put the same effort and a high magnification, even if you do an open decompression. And open with magnifying glasses or without anything, you can limit the area of decompression and the area of dural exposure as much as possible. But the tube application helps the surgeon to reduce the area of exposure. So because we use the high magnification and we use the endoscope, it's easier for us to limit the exposure. So if I do the same case with or without an endoscopic system, the amount of trauma and exposure differs significantly. So I think the endoscope provides guidance for MIS surgery. It's not that you only can be minimally invasive with the endoscope, but it helps you to be minimally invasive. Second, there's a significant muscular trauma if you do 2 or more levels despite the application of a tube system. There is a significant muscular trauma, but it will almost always be less with a tube-based transmuscular system than with an open microsurgical decompression. So even if it's a subtle difference, it's still a difference. So the transmuscular approach is muscle sparing. And the only advantage is a smaller skin incision, a smaller visible scar. Well, if so, it's still a significant advantage. Why not go for it? So a Theobox cosmetic result is still a superior surgical result, although it might not be the tremendous difference you think about. So when an endoscopic approach? Well, actually, I don't do cases if I have a very significant scarring to be expected. So if I need a lot of manipulation, like we had a case recently last week, the lady had already 4 procedures in the same level. So I expected this to be like hell. There was almost no bone. I wouldn't do this endoscopically. Second, I do not do it in cases which expect to be extremely time consuming. So like if you do 3, 4, 5 levels, both sides, difficult manipulation, I think it's probably not worth to use the endoscope, because the endoscope is for cases where you need even subtle difference gives the patient some benefit. Well, I do not do it in cases requiring a significant exposure for subsequent stabilization. So if we think about 2 levels fusion, I don't think that it really makes sense to do too much endoscopic decompression because we have a significant trauma to the muscle tissue later on. And fourth, I do not do it in cases which need an almost 360 degrees decompression. So if I have a significant decompression from the control side, like right behind the thecal sac, then probably it's better to have an open wide exposure. Well, those are actually now 4 exclusions. All the other indications, I think the endoscope gives a superior results when you use it compared with microsurgery. So with careful case selection, I think the same outcome with same long-term outcome with less postoperative pain, less muscular damage, and superior cosmetic results is achieved. And I'm sure that the endoscope will play a significant role in the treatment of degenerative spine disease in the future. And now I wait for your discussion. Thank you so much.
Thank you very much, Joachim, for this so nicely placed and nicely explained endoscopic surgery for canal stenosis. Before I start with the panelists, can I ask you one question?
Sure.
How many levels do you go for? You are comfortable with when it comes to dealing with the multiple.
It's a very good question. I think 2 levels is fine. 3 levels, if I sometimes still do 3 levels, but 3 levels, if you do 3, 4, 4, 5, 5 as one, you have a significant low doses, 3 levels is fine. If you have 2, 3, 3, 4, 4, 5, and you have no low doses, probably I would do a second skin incision. So the last case we had was 3 levels, and this this case I did a second skin incision. I feel more comfortable with this. The more you angle the tube, the more difficult it is, and the more significant is the muscle trauma.
All right, Dr. Rohidas, your comments, please.
Yeah, that's the thing, because when we try to angulate the tube more and mobilize it more, the muscle trauma is quite significant. And our primary goal is to minimize the muscle trauma. Also, the skin edges also they get traumatized. So the natural lordosis, if we can take help of that, then we'll be able to operate 2 levels to the same incision. Alpha S1 and Alpha S5 is the best.
Right. Any question for Professor Ortel from your side?
Now, Joachim, before the endoscopic decompression, we were doing the open decompression with microscope, and there used to be tendency to fix it also because of the destabilization. How the scenario has changed with the help of the endoscope, where we are minimizing the trauma to the nearby structures, and we are able to stabilize.
I think that's a very good question.
We are able to prevent the destabilization.
Actually, I will let me bring another example. Let's talk about synovial cysts, because synovial cysts is a typical indication I used to fuse all the patients.
Yes.
Why? Because it's a cyst the cyst develops because of degeneration of the facet joint. So if you just remove the cyst, the facet joint is still there, it's still mobile, it will come back. So let's say until 10 years ago, all the synovial cysts, I did a facetectomy, did decompression, and then fusion. And now we have done quite a number of endoscopic synovial cyst resections. And so far, we haven't had a single recurrence. I'm so surprised. So that now, actually, although of the development of the pathophysiology of synovial cysts, we go for MIS decompression and resection, and so far the results are excellent. So because you can reduce the trauma of the approach, I think the more and more of the of the patients, of the indications, you can try to remain minimally invasive without fusion.
When you do 2 levels through the same incision or a separate incision, in between lamina, you try to keep intact?
It depends. It depends. If sometimes if we have a significant bony compression from the lamina, then we try to undermine the lamina and unroof the lamina from below. If it's not possible, we do hemilaminectomy. I'm not that reluctant to do hemilaminectomy if I think it's stable.
If the flavum is detached nicely, the rest of the lamina you keep it intact.
Yeah.
All right, Sumit, any comments or question for Professor?
Yeah. Hi, Joachim. Right. It's always a wonderful pleasure to see you and listen to your talk. And of course, we met last in Jabalpur, and that was, of course, a face-to-face meeting. But now, post-COVID situation, glad to see you again. So, a wonderful again. Just one, I was just wondering, I saw that your patients improved on radicular pain. That is understandable after the decompression in stenosis. Your patients improved on back pain too. I mean, that too without the fixations. And I hope you meant about mechanical low backache that these patients were suffering from. And this was quite a significant amount of percentage of patients that got significant relief in the mechanical low backache. So my personal experience is that, I mean, my personal practice is, if a patient complains of mechanical low backache, he would be better off doing fixation, maybe a percute fixation, or maybe whatever the patient's condition demands, actually. So what is your experience in this regard? If a patient comes with a back pain, do you still go ahead by not fixing it and dealing it primarily by doing primary decompression?
Well, that's a very good question, Sumit. I mean, if a patient comes and has only mechanical back pain, no claudication, probably I would go for decompression, for fusion.
Fusion, yes.
But there are a significant number of patients who do not want to be fused.
Yes, correct.
They think, well, there's narrowing, just take the narrowing and I will improve.
Correct.
And of these few who do not want to be fused, actually, I'm surprised how many of these benefit from the surgery. So I think we have to be careful, but I agree with you. If a patient comes, has mechanical back pain, no radiating pain, probably
correct. I think your data answers this question. I mean, this is the question of doing unnecessary fusions. Since in your data, a significant amount of patients, and I would say tremendous amount of percentage patients, responded to the back pain also, where is the need for fixation then?
Well, the thing is, if you have radiating pain, I think then you have a good chance to treat also back pain. If you had absolutely no radiating pain,
yeah,
I'm not sure. I would still go for the fusion.
Okay.
Okay. Thanks, Rashim.
I have a question to Dr. Ertel.
Yeah.
That you told that when you have when you suspect like lot of scarring, you don't go endoscopically. So my question is, when you have a recurrent disc where there is a scarring, single level disc, not multi-level disease. So a single level recurrent disc. So what are your takes? Like, you would like to go endoscopic interlaminar discectomy, or you would prefer doing a micro discectomy in that case?
Well, disc is a difficult question because disc, frequently you have recurrent disc and you don't have much scar. So then you can come with the endoscope. But here, my topic was on lumbar canal stenosis. So if you did a significant decompression and then 5 years later, the patient has a restenosis, these cases, I think, are very difficult because usually all the dura is adherent. It's very difficult to do endoscopically. So lumbar disc, I think, is different. Lumbar disc, I think you have to make an individual approach. Lumbar canal stenosis with, a patient who had sufficient surgery, not like any mini opening. If you don't have a lot of scar, you can still go even a second time. But you had a significant exposure with the first surgery, I wouldn't do the second surgery endoscopy.
Do you advocate making some extra precautions, doing some extra precautions in doing recurrent disc surgery endoscopically?
Well, the planning. I think the planning is the key step.
Yeah.
You have to carefully analyze the data. We always do MRI and CT just to see the bony structures, because it's the easiest way is to get intraoperative orientation when you have some bone you can orient on. So all these patients get a preoperative workup, which is more detailed than usual, and then we decide whether we go another endoscopic case or not.
All right, the last quick question from Dr. Rohidas, and then we move on to the next speaker. Dr. Rohidas.
No. Do you really have seen restenosis after endoscopic decompression or microscopic decompression in lumbar canal stenosis?
No. Well, bony stenosis, no. Sometimes what we have is heavy scar formation.
Yeah.
And this can be stenotic. and I have no idea when and why this occurs.
No, but
This is, let's say, 2-3 cases per year we have. They had earlier surgery and then they come back and there's stenosis, but there's no bone. It's just scar for some reason.
But they come with radiculopathy or
no, not usually, not radiculopathy. No, back pain.
May I ask one question?
All right, thanks.
I want to ask one question. What about, we are talking about less number of days of stay in the hospital, but in your case, you follow 3-4 days rules. So that goes against the basic principle that one talks about neuroendoscopy. Is there any insurance policy or any other factor which contributes to this situation?
Well, in Germany, if you have an in-hospital patient, you have to have the patient at least for 3 days post-op. So otherwise, you don't get a sufficient reimbursement. This is, I think, a problem we have here. Also, the post-operative care and then on an outpatient clinic, on an outpatient level, is not that well developed. So it's very different from India or the States or everywhere.
I mean, because
so this is why I made this very rather attenuated, subtle comments, because I think these data you cannot use; they're useless.
I mean, in NHS UK where I work, we are supposed to discharge the patient the very next day at the most.
Yeah. This is national policies. Rohidas, do you have something to say?
Usually, this is not a problem.
In my setup, we discharge the patient second day.
Yeah, same here.
Yeah. So it is individual policy.
Stenosis, if there is no removal of the disc, the patients are quite happy after 2 hours of the surgery.
It is possible, yes. Yeah. All right. Thank you very much, Joachim, for your participation and good discussion on this topic. And Ashish, shall we go on with the next speaker?
Yes, I think. So it's my pleasure now to introduce Dr. Sukumar Sura, who is a very keen and dynamic endoscopic surgeon, consultant neurosurgeon working in Hyderabad. Now his main heading for which the slogan is that he would go for everything pure endoscopic, means he won't even use the word assisted endoscopy or anything like that. Now, he has been specializing in the cutting edge full endoscopic surgical techniques for lumbar, thoracic and cervical spine. And he has trained and proctored spine surgeons across the world. And he uses the term full endoscopic spine surgery. Now, his full endoscopic spine surgery includes microvascular decompression, trigeminal neuralgia, hemifacial spasm, glossopharyngeal neuralgia, navigation guided minimal access to brain tumors. He is also interested in functional neurosurgery, which includes epilepsy and deep brain stimulation. And of course, transforaminal lumbar, thoracic, cervical, transforaminal foraminoplasty for lateral recess stenosis, transiliac transforaminal L5S1 discectomy and foraminoplasty, laminoforaminoplasty, 360 degrees decompression of the spinal cervical canal, internamenal discectomy and decompression. So all this, of course, goes to his education and training, which is really very illustrative. He has done clinical fellowship and training on full endoscopic assisted spine fusion under Dr. Saad G. Osman, Sky Spine Endoscopy Institute, Maryland, USA. He has done clinical consultation on full endoscopic spine surgery under the mentorship of Dr. Sebastian Reuten, St. Anne Hospital in Germany. He has done functional neurosurgery training again in USA. His clinical fellowship training on full endoscopic spine surgery under the mentorship of Dr. Anthony Young, director of Desert Institute of Spine Care, Phoenix. Is trained for navigation guided ultrasound in neurosurgery by Professor Geirmund Osgaard in Norway, and surgical training on percutaneous endoscopic spine surgery from Dr. Gun Choi in Seoul. So you can see the way he has tried to get around the world and acquire his skills. That is really amazing. He is the consultant neurosurgeon of various hospitals. He has been clinical director, visiting surgeon. He, of course, is very proficient in his surgical skills and has earned a great name. He has got various awards and professional achievements, which are long list, and I'm not going to elaborate on that. And he has been visiting various centers and demonstrating his skills in various workshops on various minimally procedures in different parts of the country. And of course, he has got innumerable number of publications. So with these few words, I can't make his CV briefer than that. Can I request Dr. Sukumar Sura to start his talk, please?
Uh, Good evening, everyone. Thank you very much, Professor Pathak sir, for the introduction. So I thank our Neuroendoscopy Society, Professor Pathak sir and Sankla sir for inviting me. So today, the topic given to me is to talk about pros and cons in endoscopic spine surgery. So last two speakers almost gave a good picture about minimal invasive spine surgery evolution. So endoscopic spine surgery has evolved a great way in the last 10 years. So every day by day and year by year, the advantages are adding upon. So next few minutes, I just give a bird's eye view of what endoscopy can do. So any adoption to a new surgical technology, it's a steep learning curve. Most of the time it has these phases. So the endoscopic today is in early adopters where there is a long way to go. So maybe in coming few years, so we might adapt it faster so that we can come into the what you say peak stage. So everyone asks me about what is the best way, whether I should do learn interlaminar or learn transforaminal. So both are complementary, and as a surgeon, we should know both techniques because any central canal, as Dr. Josham said, the interlaminar approach is always better. For lateral recess stenosis, either of the two, either transforaminal or interlaminar, depending upon the surgeon's expertise. Foraminal, extraforaminal, no doubt the transforaminal approach is always better. So when you take interlaminar approach, again, we have a lot of training curve, learning curve. So the first we should learn how to do a simple discectomies, then we should do a simple decompressions. Then from there on, we should learn how to do a what you say, unilateral decompression, going to the opposite side, over the top technique, doing a contralateral decompression. So this is a long learning curve, but whatever we learn, we should learn the ideal things to do properly. So again, the concept of this endoscopy, there is always a confusion whether which technique should be called endoscopic technique, whether it's an assisted endoscopic assisted technique or it's a pure endoscopic technique. So I think this confusion should be kept aside. Whenever we talk about any endoscopic technique, the concept is it's a percutaneous technique. The technique I use, it's a full endoscopic single port technique where it's called wet technique when compared to tubular and other easy-go technique. They are dry techniques. Here we use saline irrigation, which gives excellent magnification visibility because of the bloodless field. And as in other techniques, we use angled scope somewhere between 25 degrees and 30 degrees. The biggest advantage of this technique is it can be done under local, epidural or general anesthesia. So most of my techniques I do under epidural, where no need to give any general anesthesia for especially the elderly patients and morbid patients. So, or multiple level patients, or if I am doing a spinal fusion, so then I use epidural anesthesia. And it is least invasive, as Professor Josham said, the least collateral damage with this muscle dilating techniques where you don't damage the muscle or other tissues. So as I said, it's a single tube technique where it has a working channel, the light source and the irrigation channel. So it's a one channel which the sheath acts as a retractor for us most of the time. We use radio frequency high frequency, radio frequency here, and we use a custom-made or endoscopic drill systems. So, the main important discussion here is what are the indications. So, just want to show the scope of endoscope here. So, we can do simple lumbar discectomies, either transforaminal or interlaminar, all kinds of disc prolapse, whether it's central, paracentral, lateral, or up migrated or down migrated. Foraminal stenosis and lateral stenosis can be dealt. Central canal, yes. So the bigger advantages with endoscope is you can do foraminal, extraforaminal, multiple discs in a young patient, dorsolumbar and upper lumbar disc. The biggest advantage is the upper lumbar disc prolapse, where you can't retract the thecal sacs with other systems. Here, because the lumen is very small, you can easily retract the thecal sac or the root. Or if you are practicing transforaminal technique, there is no need to handle the root at all or thecal sac at all. Dorsal disc, it's a big boon for dorsal disc prolapse patients where we can avoid big fusions. Cervical disc, a simple posterolateral or in a foraminal disc, we can easily do the posto approach where we can do laminoforaminotomy and remove the disc prolapse. Annular ulcers, this is a big chunk of patients where patients have chronic annular tears treated with conservative measures, pain management, with physiotherapy for long years. Still, there are some patients where there is a lot of granulation tissue within this annular tears, where endoscopy can scrape off all this granulation, and we can use lasers or RF to ablate this area, and we have seen excellent results in such patients. And there's a big set of patients called adjacent disc disease patients post-fusion, especially elderly patients, 10-15 years post-fusion, they develop adjacent disease, and they don't want a redo surgery or extension of their fusion, and they have only minimal back pain with predominant radiculopathy. We can use endoscopy as a good technique. And again, discitis patients where patient has either a post-op patient or a spontaneous spondylodiscitis patient, we can use this endoscope as a big boon, especially the transforaminal technique, to scrape off and debride the space and start antibiotics. And again, now we do a lot of endoscopic assisted TLIFs through transcambian approach. And there's a new technique called combined laminoforaminoplasty, where patient has a lateral recess stenosis along with the foraminal stenosis. So we can do transforaminal and interlaminar technique together, so avoiding a fusion in that patient. And as Dr. Joshim said, if patient has a facet induced pain, back pain, and patient doesn't want surgery, then we can get away with those patients with a simple endoscopic facet visualized rhizotomies, where multiple levels can be done at the same time, and patient have a very good relief of back pain. So coming to transforaminal technique, this is a posterolateral technique which we do through the Cambian triangle, which is bounded by the traversing root and the exiting root of that level with the inferior end plate as the lower border. So this is a potential space where we can enter the disc space. If problem, we can drill the part of non-articular part of the superior process and enter the disc space and tackle. And the advantages here is we can do a pedicle to pedicle clearance of any pathology and also lateral recess very easily. So with the available drills nowadays, we can drill very easily the overhanging bone, soft tissue, and lasers can be used sometimes for hard soft tissue in the neural space. So I'll just go through the examples of what I have done till now. For past 10 years, I'm practicing this. A simple patient under epidural analgesia. I use analgesic dose, not anesthetic dose. Patient motor power is still intact. Then I just go through how a transforaminal technique is done. So just marking, midline marking is done. Patient under epidural analgesia is speaking to the surgeon all the time if you want. So you can mark AP and lateral. And usually I take 12 to 13 centimeter. In average Indian patient, it is around 12 to 13 centimeter. put a needle. So once the needle is in place inside the disc space, and put a guide wire on the needle. So here we should be taking care, the guide wire should not plunge to the opposite side. So with a small stab, a few millimeter stab, maybe around 6 to 7 millimeter, because the sheath is around 7 millimeter. So you can just give a stab, pass a dilator over the guide wire. Just follow the principles of any minimal invasive procedure. The dilator should be passed along the guide wire. We should not tilt the, once it is inside, just underneath the facet, you can remove the guide wire, because you're sure that it is the facet is holding the, then with a fluoroscopic guidance, just stop gently in the lateral view, you can see, and once it is inside, you just stop it further. So you are inside the disc space. Then pass the sheath, you can see the sheath facing the superiorly between the traversing and exiting root. The bevel should face like that, so that we should not injure the root there. So because patient is only under the analgesic dose, so you can talk to the patient, ask him to move the legs at this point of time if you have any doubt. Most of the time, the dilator pushes away the exiting root, so there is no problem. So once the is inside, you can see the inflamed annular tissue. So you can use the forceps to remove this. I'm using a articulated curette to just remove the, and there are multiple drills. This is a articulated burr, which you have a hand control with a 10,000 RPM. So you can drill the facet if you want, it's overhanging or foramen is narrow, you can easily drill the facet so that our root becomes more visible. Once you are done, correlate the MRI and then remove the fragment like this. So that's a fragment which is coming out, and there's one more case you can see here, the L4, L5 disc prolapse on the left side. Again, the needle is inside. In the lateral view, always the needle placement should be in the posterior 1/3. Once the needle is there, dilator has been passed. So sheath is in situ. So the 12 o'clock is the posterior, that is dorsum. 6 o'clock is the anterior. 3 o'clock is superior, and 9 o'clock is inferior always. So you can see here now, I'm removing the disc fragments here. In this patient, it was on the left side, so I'm standing on the left side of the patient. Once the fragments are removed, so I'm just coagulating the fragments. I just withdraw the sheath a little bit. You can see the horizontal fibers there. They are the torn annular fibers and some PLL fibers, which I'm cutting there. And 12 o'clock, you can see the epidural fat. So once the small fibers are cut, again you attain hemostasis. So now we are half in, half outside. We are half inside the disc space and half outside the disc space. I'm using just instruments to remove the fragment, so that now we need to, you can see I'm using a curved instrument to remove the fragment. I removed the fragment. Once the fragment is out, we should not be very happy, because until unless we see the root and thecal sac, we are not sure whether the complete fragments have come out. Now you can see I'm just coagulating the surrounding fibers. You can see on the 12 o'clock, there are horizontal fibers and is annular tear, and I can see the fragment there. I'm removing that fragment further. I can see, I'm still not seeing the thecal sac. I can see some more fragment has come out. But still, I'm not sure whether I have removed the entire fragment. You can see there is one more, a small fragment is there. So, and you can see the good tear here. This is seen only in endoscopy, where the pathology is seen here. You can see the annular tear. I am working inside the annular tear. Now you can see the fragment has come out, and you can see a thecal sac there. You can see the thecal sac pulsations there with the fine vascularity. I'm just taking a bit of the fragment, the annulus. You can see now the two horizontal structures are the lumbar artery and lumbar vein, which run along the nerve. So just radicular artery and radicular vein, I'm just cutting that. So that here, because patient also had lateral recess stenosis, I need to decompress the root laterally also. So now I can see the root partially. So you can see there is a overhanging tissue, the yellow ligament, which is lateral to the root, that has to be removed. Now you can see I have removed the entire ligament, the lateral to the root, and the root is completely free. The fragment has come out, and the root is well pulsating with the thecal side. So this is the immediate post-op. I do in all patients. My patient immediately with the epidural catheter inside, he goes to the post-op imaging, he gets MRI done. Once a fragment removal is confirmed, I remove the epidural catheter in the post-op. So most of the patients I get a MRI immediately. So this is a small stitch. Sometimes I don't put the stitch, but patient is from outstation. I put a single stitch and send him home on the same day or the next day. So it's one more case. You can see an inferior migrated fragment. This was a case of a recurrent case. Previously, he was operated for a microdiscectomy. He came with a recurrence. So again, with the 13 centimeter, again with the same technique, went inside. And so just fast forward, this is here again, because it's the 3 o'clock is on the superior side, 9 o'clock is inferior side. So once you debulk the fragments and withdraw the sheath, you can see at the 12 o'clock, you can see the superior facet, and inferiorly it's inferior end plate, and the pedicle comes here at 9 o'clock. So all we should work is in the lateral recess at the junction of facet pedicle junction, so that we can catch hold of that inferior fragment. So now using the articulated drill, I just will drill the, you can see I'm drilling the undersurface of the superior articular facet inferiorly towards the pedicle. So it's just few millimeter drilling. So you can see I'm just debulking the fragments there. Now you can see the lateral recess is opening up. Further, I will open up the lateral recess with further drilling. So now I'll just drill a bit more. Now you can see that pedicle junction is seen nicely, correlate with the C-arm intraoperatively. Now you can see I've drilled and opened up the entire lateral recess. So now lateral recess is entirely open. Now I just catch hold of that fragment, which was inferiorly migrated, and the entire fragment comes out. So once this is done, the immediate post-op shows complete removal of the fragment, no violation of the facet joint, and the patient is happy, no fusion done. So for especially foramen and extraforaminal cases, which Dr. Satnam sir showed us before, so if we want to practice a tubular technique or a microscopic technique, we need to go lateral approach where we land on the facet and drill the pars and enter the foramen. Here we can directly enter the foramen with the medial entry and then remove the fragment. And you can see the post-op, the fragments have been removed without any violation of the facet. You can see this is a video. So you can see the root there. I'm just below the root, I'm removing the fragments. So from 9 o'clock till 1 o'clock is the root, which is seen there, and I'm removing the fragment below the root. I'm just below the exiting root. The sheath is landing just at that place. I'm removing the fragments there. So it's very easy because there will be no trauma, no handling of the root, and the post-op paresthesias are very minimal in such patients. Here, one advice is not to use too much of radio frequency where patient can develop post-op paresthesia. If a patient has a foraminal stenosis, this is a pediatrician, 65-year-old. He has an isolated radiculopathy, no back pain. So patient had inferior migrated disc along with the stenosis of the foramen. You can see the superior articular facet is boring into the foramen with kinking of apical ligament causing foraminal stenosis. So you can see pre-op the CT showing apical part of the superior articular facet is causing foraminal stenosis. So with the 13.5 centimeter, entry, foraminoplasty was done on this patient. You can see on the left side, it's a pre-op, on the right side, post-op. Nice foramen is opened up without violation of the facet joint. And post-op, you can see the sagittal images. The foramen is nice, widely open. Patient complete relief without any fusion in this patient. This is a CT, MRI of the same patient. You can see nice opening of the foramen. In upper lumbar disc, for example, this patient, she was a 26-year-old, recently married. So this patient came with a severe back pain, with groin pain. You can see such patient with any open surgery or any tubular technique or any interlaminar approach is difficult because tackling this patient needs a lot of thecal sac handling. So endoscopically, transforaminally, it is very easy. So, but as we go up, we need to take a medial entry. Here I took a 9 centimeter entry, and there were calcified annular fragments because most of the time upper lumbar has a lot of osteophytes. Either they migrate inferiorly or superiorly. So the annular fragments which were calcified were also removed, and the fragment has been removed. And this is the per-op end point of the surgery. You can see the root here. This is the L2 root, traversing root, and you can see the thecal sac nicely pulsating. Thecal sac nicely pulsating. The whole end plate to end plate, the fragment has been removed, the osteophytes have been removed, and the wonderful results of this surgery is I have a follow-up of this patient now. So you can see it was done in November 2018, immediate post-op, it was showing the fragment removal. And you can see in December 2020, recently she came for follow-up. You can see nice healing of the annulus with no bulge and no much collapse of the disc space. That's the advantage of this transforaminal approach in upper lumbar disc. We can do any upper lumbar disc with ease with this technique. Again, the dorsal disc, as I have done a dorsal disc from D7 below and not gone above. So challenge here is the rib has attachment. As we go up towards D7, D8, there is a rib head comes in the way. So I have to drill a rib in such patients with either a drill or hand drills and enter the foramina. The advantage here is in thoracic spine, the exiting route is going away, that is superior. So you don't have a problem of exactly exiting route here. And this patient presented with severe radicular symptoms. Some physicians treated for psychiatric symptoms for this patient for a long time. Then she came to me and the patient was showing a foraminal stenosis with a foraminal fragment also. I did a endoscopic discectomy and foraminoplasty for this patient. I calculate this case with MRI. So it was 6.36 centimeter from midline to avoid a lung or a thoracic entry. So you can graze the rib cage and enter the foramen easily here. I drilled the rib head here, and end point you can see this a disc space. The fragment has been removed. That's a traversing route. You can see at the 12 o'clock. And I rotate the scope superiorly, and you can see that's the exiting route. So this is the exiting route, and the traversing route, and foramen has been widely opened, and patient is very happy post-op. This is one more patient, dorsolumbar spine. Patient came with paraparesis, D12L1 prolapse. I offered initially for him a spinal fusion, but he was not willing. He wanted to try endoscopy. So I did endoscopic surgery for him. with the D12L1. He had a big osteophyte. You can see in the X-ray here. I removed took out the osteophyte also, and his 4 years follow-up now, doing fine. This is a thecal sac, removal of the disc. You can see this nice root and thecal sac with the epidural fat there. Upper and lower end plate seen nicely. All the fragment has come out. And this is the immediate post-op. You can see the fragment has come out, and patient paraparesis improved over a few weeks and still under follow-up and is doing fine. So this was one thing I was talking about. It's a chronic annular tears. We being coining the coin last few years back. It has been termed annular ulcers, where you see this high intensity zones in MRI. The patient comes with back pain most of the time, and we treat them conservatively, do physiotherapy, do pain management. But there are large set of patients where they don't improve, and we finally subject them to spinal fusions. This patient is a marathon runner, young patient, 34-year-old, husband of our nephrologist. He came to me and he said, you do as minimal as possible because he want to continue his marathon career. So it was in 2015 I operated when I put an endoscope in inside transforaminally. There was so much bleeding here. I tried half an hour to 45 minutes every method to stop bleeding, but it didn't stop because the granulation tissue was so much. So I did some innovation here. I put a small Foley's catheter and inflated that and waited for 10 to 15 minutes to stop the bleeding. Then I took down the granulation with the radio frequency, and you can see this is post-op. In 2019, after 4 years, it's completely healed, and the patient is now again doing a complete marathon again. He has completed 2-3 marathons already. So this is the advantage of endoscopy, where this large set of patients we can offer them endoscopic debridement and RF ablation of the granulation, so they improve a lot. Then adjacent level disease, you can see this patient was fused 15 years ago for back pain and instability. That level is okay. For now, the lady is 64 years, yoga teacher. She doesn't want extension of fusion. She has adjacent level disease with the bilateral radiculopathy. So you can see a disc prolapse with foraminal stenosis. So this patient, I did a bilateral decompression and did a foraminoplasties bilaterally. And this is the end point where you can see a thecal sac and the root nicely decompressed from pedicle to pedicle. And this is the exiting root you are seeing on the right side. I'm rotating the scope. This is the dorsal root ganglion with the exiting root. So you can see the traversing root, exiting root, and the tissue between has been entirely removed, and this patient recovered well. So the most of the cases discitis can be tackled here in this patient. This patient was a renal patient, was underwent multiple renal procedures. Patient developed spontaneous discitis, and patient didn't want any further surgeries, and we convinced them because patient was not getting better with empirical antibiotics. So I did a transforaminal decompression on this patient. So to our surprise, it was enterococcus, and you can see putting a needle. I am aspirating the abscess there. It's a frank pus, and which can be easily done with a simple technique. Patient under this patient we did under local anesthesia because we didn't want to give him any chance of infection, putting epidural catheter. So this was done under local with some sedation. So, and once pus was aspirated, I did in decompression, debrided the tissue, removed the tissue for culture, and it came as enterococcus, and luckily was sensitive to penicillins and other simple drugs, which he recovered very well later. So we also do transforaminal endoscopic, we call it as assisted fusion, because we do end plate preparation using endoscope. Then we use a cage removing the scope. So for this patient, especially, you can see patient has a instability with a disc prolapse with canal stenosis. So here we can utilize our endoscope transforaminally. First end plates were prepared with visualized end plates, preparation, removal of this one with artificial bone graft mixed with bone marrow, pack the surface, the space with graft, then place the cage, appropriate cage. Once it is done, percutaneous screws were placed. Then interlaminar approach, you do a decompression bilaterally. Ipsilateral, then go over the top. So bilateral decompression. So you are avoiding a fusion here. So this is the cage insertion. You can see this is the cage inserted with the graft after packing the space with the graft. And once I'm coming out, I'm seeing, confirming this is the exiting route. I have not injured the exiting route. All my transforaminal fusions I do under epidural analgesia with neuromonitoring. So we have a series of cases now. We have done with neuromonitoring around 12 cases till now. So the advantage is that whenever we are putting the cage inside, if patient complains of pain, we can see with the neuromonitoring whether it is a stretching pain or the neural pain. We can easily identify and change our trajectories. So this is a cage inserted, and you can see this is a post-op imaging. This is one more case, again L4, L5 instability with disc prolapse. So this is a sheath which placed inside. We pass an endoscope, do a disc preparation and plate preparation, pass a guide wire, remove the sheath, then over the guide wire we pass a cage with a neuromonitoring. Then once the cage is inside, with a simple standard percutaneous technique, put the 4 screws and fix it. So patient goes home on the same day or the next day. So this is the transforaminal scope. We have seen almost a wide spectrum of cases can be done with this technique. The interlaminar, again, all this time, since last 1 hour, we just saw the microscopic, microendoscopic, tubular, and again tubular endoscopic techniques and distendo techniques. So this is just one more technique where the concept is same, but here we operate under irrigation, and most of the time the sheath itself acts as a retracting tool. So again, it's the same advantages as any other endoscopic technique. Added to that, because of the irrigation, we have excellent visibility, and positioning same. And here we can do either under epidural or under GA. So if it is fusion, I do under epidural. Otherwise, I do under GA, because if I'm doing a stenosis, it takes longer time. Sometimes patient find difficult to lie down 2-3 hours on this position. So just for example, how a simple discectomy is done. It's L5S1 disc prolapse with radicular symptoms. Young lady, 24-year nursing staff. So marking is done. The advantage of this technique is only 2 to 3 C-arm shots are required. In transforaminal technique, there are more C-arm shots. And here just one dilator, and after that use the sheath, which is 8 mm sheath. So only the 8 mm compared to other techniques, it's 8 mm sheath. Once this is there, you can see here the irrigation port. This is one more suction port, and this is a working channel, the light source and the camera system. And there's a way you hold it, is ergonomically where your hand should not pain, and you can do up and down like this. The advantage is you can steer it as you like, superiorly, inferiorly, and medially, laterally, very easily. So once this is done, you can see here, this is small muscle bits you can see here, just coagulate, and you need to remove 2 or 3 millimeters of muscle just to once, because the sheath is very small, it is easily accommodates in between the interlaminar space. You can, the moment I remove a small bit of muscle, you can see the yellow ligament there. So you can just coagulate the bleeders and you are seeing the yellow ligament already. So once you see the yellow ligament, you just give a small cut in the yellow ligament. Once you cut, you can see the saline itself will push the structures down, and you can see, visualize and cut. You can see, visualize and cut. The advantage is you can take the scope as near as possible. That's the biggest advantage of this technique. The endoscope can be taken as near as possible. You can see the fine globules of fat is seen, and the vessels over the nerves are seen so clearly. And you can just remove that fat to just identify the lateral edge of the root. You can see now I am seeing the lateral edge of the root, and with the sheath itself, just push the sheath inside and use this sheath as a retractor. You can see the lateral edge, that's the lateral edge of the root. And I am using this sheath, pushing the sheath just deeper and using that as a retractor. You can see just I rotated it and my root is retracted now, and I am just free to operate in the disc space now because there is no root and there is hardly any retraction. So advantage of this, one more advantage is that you don't retract too much here, and just put a nick there and cut the lamina and do a discectomy. So the one more example of inferior migrated disc, you can see inferior migrated disc. Again, the left side and complete disc has been removed. Stenosis, as Dr. Joshim already showed, wonders can be done with this endoscopic interlaminar approach. The added advantage is that you can see into the corners. You can see one example, this lady has a stenosis with no back pain. Most of the symptoms were claudication symptoms. So you can see here, there is a less disc, more of yellow ligament component here. And again, using a stenoscope, which is 10 mm dia. So I just use a 10 mm sheath here. And this is the end point. Once I've done a ipsilateral and contralateral decompression, you can see this is a contralateral. I am just sitting on the top, and you can see this is a contralateral lateral recess, completely decompressed. Nicely thecal sac is seen. That is the root there. That's the disc space. That's the root. That's the disc space there. Completely decompressed. This is superiorly. Entire sublaminar yellow ligament has been removed completely. It's the spinous process, underneath the spinous process. And I'm coming to the ipsilateral lateral recess now. And lateral recess.
Dr. Suraj,
it's ipsilateral recess. Completely, you can see the root here. It's a root with some, that's a root. Completely lateral border of the root is seen. So you have decompressed the bilateral lateral recess. The central canal has been completely decompressed. So with the good irrigation and the radio frequency, that's a disc space. And inferiorly, you can see completely ligament has been removed. So there's no ligament, and the overhanging facet can be easily removed. So
Dr.
this is the end point, and you can see immediate post-op shows posteriorly the complete ligament has been removed, and the entire central canal has been decompressed.
Can you conclude this thing, Dr. Sura, please?
I have done around 7 cases till now, and luckily there are no recurrences, and there are no need for any fusion. So again, this right side radiculopathy. This is a 78-year male who was a Air Force pilot before in World War II. So he came to me with the severe radicular symptoms. You can see here the facet cyst has been decompressed. It's a material which is there. He was given epidural steroids twice, but no improvement. And there was percutaneous CT guided aspiration was also attempted on this patient. Once the cyst was removed, I just decompressed the entire lateral recess. You can see the root there. The lateral recess has been completely decompressed. Facet cyst has been removed, and You can see here the root is completely free. And this patient was very happy post-op. He stays in United States now, and the 2 years follow-up, he is happy now, and no recurrent symptoms. So the complete cyst has been removed, and in such a old man, no need to do any big procedures. So limitations, till now we discussed the scope or spectrum of what endoscopy has achieved or has grown over the past years. But still the cons are the big learning curve, adapting to a open surgery or a fresher adapting to endoscopy, learning the depth perception, the 2D, 3D anatomy, and the coordination of instruments. The gentleness of the instruments is very important in endoscopy. We break the instruments quite often, and the cost of initial setup and the recurring cost, especially I get a calls by so many beginners saying that they broke their scope and it is costing them very huge money. And the instrument, once there is a breakage of the instrument, it is very costly. So these things over a period of years, initially even first my 2 years of surgery, I broke 2 scopes and so many instruments, but last 8 years, so luckily I am not had any such issue. But yes, this is a problem where the cost of initial setup and recurring costs and the proper training, as Dr. Satnam sir said, in India and abroad, the structured or comprehensive training is lacking, though Dr. Rohidas sir has taken so many pains for past almost 20 years to teach people handheld, so many students to train them, but still there are a lot of scope and efforts are still required to train the people. So the learning curve and training are the big cons of this technique, but I hope next coming 5 to 10 years we achieve that and have some structured training and reduce this learning curve. So thank you for the opportunity again.
Thank you, Dr. Sukumar.
Thank you,
that was a very elaborate demonstration of your skills. No doubt we can see the excellent results.
Any questions?
Should we ask Professor Oetel to comment on the talk or any questions he wants to ask?
Hello,
So
any
actually,
questions, sir?
I think my major concern is if you want to tell beginners what is the case you want to start with and what is the case you do recommend not touch. Just simple cases, just simple description.
I'm not able to hear.
He's not able to hear.
Which are the cases you would tell the beginners to start with, and which are the cases you'll tell the beginners not to do?
I think he's not able to hear.
Yeah, now I'm able to hear, sir. Yeah, sir. I didn't get the question. I didn't hear it.
The question is, for the beginners, what would you suggest? Which are the cases they would start with, and which are the cases they should not do?
Thank you.
Yes, sir. For beginners, I always suggest they start with the transforaminal technique, selecting a simple disc prolapse, which is acute disc prolapse, not taking any cases which have a stenosis component or a chronic component. So ideally, a simple disc prolapse, which is very acute in a young patient. He is the best ideal case for a transforaminal technique. He is the ideal case for a beginner.
What is the case you recommend not to do?
So definitely the degenerative cases and the stenosis cases are not for the beginners. Once they are well versed with the anatomy and instrumentation, then they can try endoscopy in such cases, advanced cases like stenosis in the form of lateral recess, foraminal stenosis. But patients who have predominant back pain with degeneration, these patients, if you don't try to address the pain generator, if patient has a component of facet disease, component of discogenic pain, and a component of stenotic pain, and if you only do a disc decompression, such patients will come back with a lot of pain, residual back pain or a new pain. So such patients, so always the hypothesis of pain should be very clear, that where is the pain coming from. Without that, I don't think we should not attempt endoscopy. And I say we should not try endoscopy in all cases. I see patients, I see beginners posting me that can I do endoscopy, very difficult cases. So every case is not a case for endoscopy. Even I do open cases even now today, multiple level disease, lot of facet arthropathy, some predominant back pain. I still suggest go for open decompression and fixation rather than isolated endoscopic surgery.
Thank you.
Do we have still time for two more questions, or is it time up?
No, please.
No, go ahead, please. Go ahead.
Go ahead.
Okay. Another question. There's a big discussion here, at least in Germany and in Europe, about the transfemoral technique. One prefer the inside out, so they enter the disc, do discography, and then they retract. And the others say, well, never do this, because then you perforate the annulus and you make a huge hole and the results will be bad. So what is your opinion about this?
I practice in between. See, because I'm a neurosurgeon, started with my career with microscopic surgeries. So what we do in microscopy, we do a small annulotomy, and with the crisscross annulotomy, we enter the disc and remove it. And if you have any osteophytes around, we try to break these osteophytes and clear the neural structure from end plate to end plate. We don't want any structure to compress the nerve root. So this is our concept, right? So when we are practicing endoscopy, when you say only enter the disc and debulk it, then you are wrong. Only go outside and remove the fragment which has popped out, then again it is wrong, because when you are removing, when you follow a outside in technique and you remove only a fragment which has come out, there are multiple fragments which are lying deeper just below the annular tear, and you might miss those fragments. And with endoscopy and angular scope, it is very difficult to hold the deeper fragments. At the same time, when you have entered a disc deep inside, it is very difficult to operate just below the root. So I follow a modified technique where I enter the disc space, come out a little bit, do a small annulotomy and find out the nerve root and remove whatever underneath the nerve root from top to bottom, that is upper end plate to lower end plate, clear the nerve root, make it free in all cases, so that I am not leaving anything there. And it's like same as our micro discectomy. Only advantage is that here you are not violating, you are not retracting the nerve, you are going underneath the nerve. And a big advantage like central discs or like a big disc like causing cauda equina syndrome, you are entering the disc and pulling the disc from inside. So it is very easy without handling any neural structures, you are able to remove the material. So to answer to your question, the debate always is there, and people who are promoters of outside in and promoters of inside out, they keep debating and they keep fighting. But the bottom line is, if you don't decompress the neural structures and remove the loose fragments, we are bound to have recurrent fragments or residual back pain post-op.
Okay, one more question. Sometimes we have patients who suffer from a disc prolapse for many months or years. So do you do like a routine workup if you're suspicious of calcification? Do you do CAT scan in all the cases, or is there a particular criteria if you have a long-standing disc problem, not rather to go to open? Because we know this, that sometimes even the myth of interdural disc prolapse, I mean, this is Sometimes it's intradural, but only if it has been many, many years thinning out the dura and then migrating inside. Is there any thumb rule you would say, well, I do not do this endoscopically because I expect it to be difficult?
When I suspect osteophyte which has formed over a period of years, whether a complete osteophyte or a partial osteophyte, there are two types of patients where the osteophyte itself causing the stenosis, or there is a breach in this osteophyte somewhere, either inferiorly or superiorly, and the acute fragment comes out through that space and further causing acute symptoms on chronic disease. So if such is the case, most of the time with the disease is chronic, and in MRI, you see a lot of hyperintensity signals on the disc surface. I do a CT scan to rule out the morphology of osteophyte. And in the such cases, I go interlaminar rather than transforaminal, because in transforaminal technique, it is difficult to remove a thick osteophytes. So I go interlaminar, break all osteophytes, and with interlaminar stenoscope, you can break all the osteophytes and remove the entire fragments very easily, because you are just landing on the fragment, landing on the osteophyte, just retracting the thecal sac with the sheath, you can just remove the complete osteophyte. So I go interlaminar rather than transforaminal.
I don't have any other questions.
Dr. Rohidas, please.
Yeah, he just, Dr. Sura, you just told that you with the interlaminar stenoscope, you are happy with the decompression which you achieve. But still you said that you still do some open cases.
Yes.
What is the reason?
Because when I see a multiple levels, and I see facet disease is a big issue. When with the stenosis only you address the canal and remove the ligament and the bilateral root decompression with some facetectomy on either side. But still patient come back with the back pain because of the residual facet arthropathy or micro instability which patient has already. So such patients where there is a facet arthropathy, I better go for a open surgery, open T-leaf, fusion rather.
So when you think of a fusion, you go open.
Open. Otherwise, no open. Most of the cases I do endoscopy.
Where to schedule your doctor's
Dr.
appointment?
Sumit?
Thanks.
Dr.
There's a
Sinha, are you
simpler
there?
way to get
Yeah,
your
yeah.
health questions answered.
Yeah.
Hello, can you hear me?
Empowered
Yes, sir.
Okay, great presentation, Dr. Suru. I mean, it's wonderful. I've been following your work for quite a long time now, and keep on seeing your post on WhatsApp and Facebook and all. Wonderful, very applaudable. As you very rightly said, I mean, this is for the young practitioners who are listening over there. As you very rightly said, that the operative procedure should not be done for the sake of doing that operative procedure. And of course, endoscopy, it is very, very true for endoscopy. Endoscopy should not be done just for the sake of doing that. We have to keep in mind, anyone who does an endoscopy has to keep this in mind, that there are specific indications for doing an endoscopic procedure, be anywhere, be inside the brain or in the spine, or whatever disease you are doing the endoscopy for, specific indications. If you outreach these indications, if you use endoscopic procedure beyond those which are recommended as ideal indications for that endoscopy, your endoscopic procedure might fail.
We've done past work showing that ventilation not only
now here is an exception that all these presenters over here who are presented today, they are world class. They are the masters in their technique. So this is a word for young practitioners. The kind of cases they show and the kind of surgical outcome they show for their cases may not be applicable to the novice. So the novice should do an endoscopy only in that ideal indication, at least to start with. If they want to have good surgical outcome, and if they want their surgical patients not to return to their clinic without any improvement. So this is my take on endoscopy.
Thank you.
Followed by rheumatic
And
arthritis,
Dr.
followed
Rashid.
Can I add something on this? Because
Yeah.
this is a very important point. I think it's very important that you know the anatomy. It's not that much the microsurgical technique, it's that you know the anatomy. So I think it's mandatory. You have to do at least 100, maybe 200 spine cases open just to know exactly where you are. Because the problem of the endoscope, regardless which technique, you don't have the overview you used to have with the open approach. I think this is a very important aspect. If you don't know exactly where you are, every technique becomes dangerous. So I think that's a very important point, that we have to train the young ones that they know exactly what the anatomy.
That's true. Thank you. Thank you very much for those important words. Dr. Rashim Kataria, anything?
I must congratulate Dr. Sura for an excellent presentation, and especially for the use of transforaminal surgery in upper lumbar cases, sir. And I must thank the Neuroendoscopic Society for this wonderful webinar. Thank you so much, sir.
Dr. Rohit wants to ask something again.
One should understand the pathological anatomy, what he wants to have at the site of the pathology. Suppose it's a canal decompression, what he wants to achieve, and then choose his technique. It should be reverse way. For a particular case, what he wants to achieve at the site of the pathology, and then he can choose the technique, rather than choosing the technique and then going inside and then having problems of not achieving it.
Absolutely right. Yeah.
To the patient, seeing the symptoms, and then deciding with the radiology, and then coming to understand what the pathology is.
Yes.
So it's a long way.
Otherwise, each and every case is a different case. There is going to be problem.
Great. I think that brings us to the end of this wonderful session today.
Are there any questions in the chat box?
There are questions, but I think they have all been answered. I'm with the questions here. So most of them have been covered in a different form. So
okay, perfect.
I hand over the mic to the president, and we make the final announcements.
All right. Thank you very much, Dr. Pathak, for conducting the seminar. And I would like to thank all the speakers. They have presented excellent material today, and we had a fabulous discussion today on various procedures performed endoscopically on the spinal diseases and disorders. So thank you very much, all of you. And shall we, invite Mr. Naik to do the closing remarks?
Yeah.
If he's around.
Good evening to all of you. Thank you very much for joining us today. You must have had a wonderful learning session today from the experts from Global Scenario and from India. Professor Joachim Ortel. This is the second time I think Sir has come to educate the Indian surgeons, and the other speakers, Professor Chabra and Professor Sura. Thank you very much for your presentation and a lot of learning that you have given to our young neurosurgeons. As Professor Ortel said, it is anatomy, and first few cases has to be open surgery before you go on to the endoscopic surgery. Panelists asked very insightful questions to unravel the mystery of endoscopic surgery. Professor Rohidas, we have been fortunate to have him often in our webinars. Professor Sumit Sinha and Professor Rashim Kataria. Thank you very much for your insightful questions. And thanks once again, Professor Suresh Sankla, for conceptualizing this webinar series for Neuroendoscopic Society of India, ably supported by Dr. Ashish Pathak. From Health and You, we have been fortunate to carry this session and enjoying this session throughout. This is the 6th episode that we had the opportunity to carry. We thank our speakers, our panel members, and the organizers, and of course the viewers. Have a wonderful new year and a great learning continued in this new year 2021. And I hope you get your shots of vaccines very soon, and then it follows to us. Thank you very much. Please continue to support Health and You. We are happy to carry these academic webinars. We had 217 logins today from 217 logins today from 3 different countries, and 10 logins have come from abroad. So the numbers have been good in spite of so many webinars happening around. Thank you very much for following this series from Neuroendoscopic Society of India.
Thank you. Thank you very much. Yeah.
Thank you. Bye-bye.
Thank you. This is Deepak Naik signing off from Health and You. Thank you. Thank you. Thank you so much.
Ashish.
Just to remind you, the next webinar is on 14th of February, and that would also have spine part of it. So please don't forget to join us.
All right. Thank you. Thank you very much.
Thank you. Have a good night. Thank you.
Thank you.
Auf Wiedersehen. Auf Wiederhören.
Auf Wiedersehen.
Over the Zen. Yeah, okay. Great. That